Very happy to introduce Rebecca Randell. She is a good friend and good collaborator. She comes to us from the School of Healthcare at the University of Leeds. She's actually at California for a conference, and I invited her to give a talk after that. So she's actually trained in HCI and the software engineering field. I remember I first met Rebecca in 2009 when she was, at that time, she was organizing a workshop at the CHI conference. And over these past few years, she has slightly moved more towards healthcare. And she's done a lot of really interesting projects. I think 2 years ago, I heard a talk about using new technology in the pathology field. Today, she's going to talk about her new project regarding robotic surgery, which is very interesting. I actually shared this talk with a couple of doctors I know who's doing this kind of surgery. Unfortunately, they're too busy, they don't have time to come, but I will send the link and video afterwards for that. So Rebecca her papers has won many interesting awards. In 2004, she was awarded with the Diane Forsey Award by the American Medical Informatics Association. This is the only award in the American Medical Informatics Association that recognizes the contribution in the field of social research and healthcare, which is 2004. I really wanted to mention that that's even before I entered into this field. So she really did a lot of really interesting work and really influenced many of my work. So I will pass this to her and she will talk more about that.
Lovely, thank you very much. So I'd like to start off by saying thank you to Yunan for inviting me and giving me this opportunity to talk to you today. At the University of Leeds, we're using an approach called Realist Evaluation to undertake a number of studies of technology use. So what I'm going to do today is I'm going to present findings from a particular realist evaluation that we're doing, which is looking at how robotic surgery gets introduced into practice and its impact on teamwork and decision making in the operating room. But as the title of the talk suggests, I also wanted to take this as an opportunity to take a step back and think about the methodological implications of our work in terms of how realist evaluation can contribute to understanding the use and implementation of technology, and also how it could potentially contribute to design. So I'm going to start off by explaining what realist evaluation is and why it's appropriate for studying technology use, and I'll tell you a bit about some of the studies that we're doing at Leeds using this approach. I'm then going to move on to talk about the study of robotic surgery, so I'll give you some background to that. And then I'm going to present the methods and the findings from the first phase of that project on robotic surgery, where we did interviews with surgeons and surgical teams to get their perspective on what's needed for robotic surgery to be effectively introduced into practice and how it impacts teamwork and decision making. I'll then talk a bit about phase 2 of the research, and then I'll reflect on the relevance of realist evaluation for studies of technology use, and then I'll be happy to take any questions. But before I do that, I thought it would be useful to say a bit about me to put this work into context. So Yunan's already given me a very nice introduction. So as Yunan said, my first degree was in software engineering, and I then did a PhD in human-computer interaction, where I did an ethnographic study looking at nurses' use of equipment in the intensive care unit. So since then, my research has all been either studying how healthcare professionals work in order to inform the design of technology, or looking at how healthcare professionals use technology in practice. And in doing that work, I've moved between computing departments and healthcare departments, so I see my work as being at the intersection of human-computer interaction and health services research. Okay, so why realist evaluation? Technology depends on human agency to work. So technologies in and of themselves don't produce change. It's how people choose to use the technologies or not, how they choose to use the resources that a technology offers to them, that produce those impacts that we think of being the impacts of technology. And those choices that people make about how to use the technology or not are highly dependent on context. So you might introduce a technology into a particular setting and it has the desired impact, but you're unlikely to see that you get the same impact across all settings. So realist evaluation is an approach that explicitly recognises this. So as well as asking what works, it seeks to answer the questions of what works, for whom, and in what circumstances and how. So realist evaluation is an approach that originally came from evaluating complex social programs. In particular, it was started for the evaluation of offender rehabilitation and crime prevention programs. But it's increasingly popular for evaluating complex interventions in healthcare, and that includes healthcare technologies. But as I'm going to argue, I think it also has relevance for evaluating technology more generally. So realist evaluation seeks to answer the questions of what works for whom, in what circumstances and how, through eliciting, testing and refining stakeholders' theories of how the intervention, of how a technology works. So you might start off by talking to the developers, the designers of an intervention, of the technology, about how they think it's going to work, the ideas that have motivated the design of that technology. You might expand your list of theories for testing by talking to the people who are introducing that technology into a particular setting. So what impacts do they think it's going to have and how? And you might also talk to the users themselves about the technology. So these theories we refer to as context, mechanism, outcome configurations. So these context, mechanism, outcome configurations, they describe the mechanism by which we mean the recipient's responses to the resources that the technology provides, the contexts in which those mechanisms are triggered, and the impacts of that, the impacts of those mechanisms. So to help explain this concept, I thought it would be good to kind of give you an everyday example away from the healthcare context. And I should also say, when I'm talking about theory, we're not talking about grand theories. We're just talking about ideas about how technologies work. So we all have these ideas. We all have ideas about why they produce particular impacts. And it's often what motivates either the development of a technology or its implementation. So at the University of Leeds, a couple of years ago, they started introducing automatic lecture capture, where lectures would be video recorded and available online for students to review. So looking at the university web pages that describe the introduction of automatic lecture capture, it's very clear what the theory of those people leading that introduction, what their theories were. So the resource, as they saw it, was the ability for students to review lectures wherever and whenever they want. And they anticipated that the response of students to this would be to review lectures to help understand complex material and to help them with revision, with the consequence that student learning would increase, and this would be reflected in higher exam scores. But what this doesn't consider is the context. So it's unlikely that all students will have the same response to that technology. So in realist evaluation, when we talk about context, we're not just talking about setting or location. So you could have context at the micro, so the individual level. You could have it at the meso level, so it could be to do something to do with the module, the particular degree program. It could be something to do with features of degree programs at that university, or it could be macro level context. So for example, national policies. So for example, in the UK, national policies about tuition fees and how that impacts students' attitudes towards their studies. So we could imagine that this theory works for engaged students. But then if you have unengaged students, or students who are less confident, maybe they're shy, they don't want to go to lectures because they're worried about being asked questions that they won't be able to answer, they might have quite a different response. So it offers them the same resource, but they might interpret that as meaning that they no longer need to attend lectures because they can just watch it online, with the consequence that you get reduced engagement and dropout rates increase. So as I said, at the University of Leeds, we're doing a number of studies using realist evaluation. I have 3 PhD students who are using realist evaluation. So one looking at trainee doctors' use of smartphone applications to support their decision making. One looking at quality dashboards on hospital wards, and then using technology in the broader sense of the term, one on devices for reducing heel pressure sores in hospitalised patients. Then we have the evaluation of robotic surgery that I'm going to be talking to you about today. A realist evaluation of digital pathology, which we've recently started. And then we're about to start a realist evaluation of electronic whiteboards on hospital wards. So I'm going to move on now to talk about our study of robotic surgery. I'd like to acknowledge the team that are doing this work with me, and also to acknowledge our funder, the Health Services and Delivery Research Programme of the National Institute for Health Research. So I thought it would be helpful to give you some background, to tell you how this study came about. So I met with David Jane, who's a professor of surgery at Leeds and a colorectal surgeon. And we were talking about some ideas for research, and he invited me to come and observe 2 operations. one using keyhole surgery and one using robotic surgery. So I did, and what completely fascinated me was the different spatial configurations in these two operations. So in keyhole surgery, the surgeon and the rest of the team are all around the patient, and they're all looking at the same screen, which gives you a 2D view of the surgical site. In robotic surgery, the Da Vinci robot helps the surgeon to carry out a keyhole operation. So the surgeon sits at the console, away from the patient and the rest of the team, where he has a 3D view of the surgical site, and he controls the robotic arms which hold the surgical instruments. So he's looking at this 3D image while the rest of the team continue to work with the 2D image. So at the time, the work around surgery that I was familiar with were the qualitative studies, the ethnographic studies that emphasised the careful collaboration and coordination in surgery. The way, for example, the scrub nurse will monitor what's happening so that she can anticipate what instrument the surgeon's going to want next and can pass that instrument without being asked. So for me, one question was, well, what happens to that careful collaboration and coordination when you move the surgeon away from the patient and the rest of the team? I was also interested in the impact of this on decision making, because existing studies of surgery have shown how the positioning of team members and technology influence the gathering of information that's used to support decision making. So I went away, and while I could find paper after paper talking about how important teamwork is for safety in the operating room, I could only find 2 small studies looking at the impact of robotic surgery on communication. So these were 2 small quantitative studies. Both studies found a significant increase in oral communication in robotic surgery. But what they didn't look was, well, what happens as a consequence of this? And also what happens to the non-verbal communication that's been shown to be such an important part of teamwork in the operating theatre? And also what strategies do the teams develop to manage these changes? And I could find no studies looking at the impact of robotic surgery on decision making. So those were 2 key areas that we wanted to look at. But as David and I discussed it more, he raised the topic of how robotic surgery gets introduced into practice. So robotic surgery makes it easier for a surgeon to do a keyhole operation. It provides them with increased precision and control, which could potentially lead to improved patient outcomes. I say potentially because there's a limited evidence. So in prostate cancer surgery, it's been shown that with randomized controlled trials, that there's no difference in the cancer outcomes, but it is better in terms of longer term quality of life outcomes to do with continence and sexual function. But in other areas of surgery, there's a real lack of strong evidence. So these robots cost $2 million each. But at the time, there was anecdotal evidence in the UK that these robots weren't being used as much as they could be, so that the full benefits for patients weren't being realised. So again, I went back to the literature and how to integrate robotic surgery into practice was again something that hadn't previously been explored. So David runs ROLAR, which is an international randomized controlled trial comparing robotic and keyhole surgery for the curative treatment of rectal cancer. So we decided that we would run our study alongside that trial, looking at the UK sites, at how they'd introduced robotic surgery into practice, and how robotic surgery impacted teamwork and decision making. So I'm going to talk about the phase 1 of our research, which is the theory elicitation phase in realist evaluation. So theory elicitation is normally done either through identifying stakeholders' theories in the literature or through interviewing stakeholders. We decided to use a combination of these approaches. So in preparing the grant proposal, we'd looked at the literature on surgical safety and the literature on how technologies get integrated into practice. So we had some initial theories from that. Then we started the project and we did a supplementary literature review. So when we'd been preparing the proposal, we found that quantitative studies of robotic surgery, so these were typically case series written by surgeons describing, we've done this X many cases using robotic surgery and these are the outcomes. In the discussion section would often include the author's reflections on how they successfully integrated or how they got robotic surgery started in their institution. So we went back and we looked at those studies, and we also searched for the grey literature, because stakeholders' opinions are also to be found in things like editorials and opinion pieces. So we also looked at that. So that provided us with the basis for our interview study. So we used a particular approach to do the interviews called the teacher-learner cycle. And this is a particular approach that comes from Realist Evaluation. So in teacher-learner cycle interviews, it's the researcher's theory that's the subject matter. So we presented the theories to our interviewees and we asked them to draw on their experience of robotic surgery, to reflect on those theories and to tell us to what extent and in what ways those theories fitted with their experience. So we did 44 interviews across 9 hospitals, interviewing surgeons, anaesthetists, surgical trainees, theatre nurses and operating department practitioners. So I'm going to present now some of the theories that came up in the literature review and our interviewees' responses to them. But I just want to say before I do that in presenting these theories, we're not saying that either theory is true. So the theories from the literature review provided a basis for exploration in the interviews, and those interviews, the refined theories that have come out of those, have provided a focus for data collection that we've been doing in phase 2, where we've been video recording and observing both keyhole and robotic operations to test those theories. So I'm going to start with a couple of theories about how robotic surgery gets integrated into practice. We started with the theory that robotic surgery is more likely to become embedded if the whole team receives training. Those people that we'd interviewed who had trained as a team agreed with this, saying that doing the training together increased the understanding of the impact of the robot on each other's roles. And it also increased trust in each other's knowledge, so the surgeon felt more confident that his team would be able to support him in undertaking a robotic operation. They also talked about the benefit of it in terms of team bonding. So they would go off for a weekend to Paris or Strasbourg, to one of the Da Vinci training centres, and they saw this as being really important. So they talked about the theatre, the operating room teams would talk about, we don't mix in the same circles. We would never socialise out of work. So this was a bonding experience, and they felt that helped contribute to the improved teamwork that you need in robotic surgery. The second theory we had was that a dedicated robotic team are more quickly able to gain experience and learn ways of working together, which would lead to a reduced operation duration. Our interviewees felt that wasn't practical in the long term, but they did think it was really beneficial when first introducing robotic surgery in allowing the team to develop confidence in the things that they needed to do for robotic surgery. So the literature on the learning curve talks about the surgeon's learning curve, but it seems that there's also a learning curve for the team. And in the same way that with the surgeon, it's not just about the total number of operations, it's about the frequency of those operations. The same's true for the team, and that if they're not doing those operations frequently, it's difficult for them to become confident and to do those tasks kind of in a routine way. So moving on now to think about teamwork, what was interesting with the theories about teamwork was not only did people tell us about the challenges they experienced with teamwork in robotic surgery, but they also told us about the strategies that they developed to try to overcome those challenges. So we started with the theory that communication is worse with robotic surgery compared to keyhole surgery due to the distance between the surgeon and the rest of the team. Although from the literature it wasn't clear why this was or what the impact was. So the theatre team said that yes, it is sometimes difficult to hear the surgeon, particularly if there's problems with the microphone. So the robot has a microphone and speakers, but they often reported that there were problems with these. Or if you have a surgeon who speaks unclearly. And this is kind of made worse by the absence of non-verbal communication. So you can't use gaze and eye contact and gestures to communicate. They also said it's sometimes unclear who the surgeon's speaking to. So this can result in repetition of instructions. So the surgeon realises no one's heard him because they haven't responded with either words or actions. Requests to repeat information, which in turn leads to reduced coordination and potentially a longer operation duration. So as strategies to overcome this, one thing that the surgeons talked about was saying that what you need is very clear, explicit communication, and they acknowledge that they need this in a way that they don't do in keyhole surgery. So this actually led to a new theory amongst the surgeons that because of the physical separation, you need more explicit communication. So in fact, the communication's better in robotic surgery than it is in keyhole surgery because it has to be. The other communication strategy that was described by the theatre teams is what's known in other domains as readback. So is this theatre nurse describes, "I would always say, scissors coming out, Maryland going in, whatever." So the surgeon always knew loud and clear that we've not only heard them, but we're actually doing it. Another theory that came up in the interviews that hadn't come up in the literature was about engagement. So some of the surgeons felt that in robotic surgery, and I say the surgeons, but in fact the scrub staff also agreed with this when we talked to them about it, that the scrub nurse and assistant are less engaged in the operation. So they're talking, they're not watching the monitor, because there's less for them to do in a robotic operation. So as this surgeon describes, "I'm the only one working, and because I'm the only one working, everyone else's attention gets distracted, including the assistant, and they start chit-chatting away, and then occasionally I'll be sitting there with a tied suture waiting for them to cut. I look over and they're chatting away." So this suggests that the lack of engagement has an impact on coordination, that the scrub nurse and assistant aren't able to anticipate what the surgeon wants because they're not watching the monitor, and then if he or she asks for something, they don't hear it, so potentially increasing operation duration. However, the surgeons suggested some strategies for increasing engagement in a robotic operation. So one thing was to provide a commentary, so for the surgeon to talk through what they're doing to help keep the team focused on what's happening. And the other thing was to emphasise the team's responsibility for that operation, their responsibility to monitor the screen. So as the surgeon describes, if they feel that there's a responsibility for them in that patient, they'll feel valued and they'll work with the team. If they're treated like it's your job to just give us equipment, it's your job to suck the smoke here and there, I think it becomes like a job rather than part of a team. Okay, and then we had this theory about coordination, that when the surgeon's separated from the rest of the team's less aware of the surgeon's actions, making it more difficult to coordinate their actions during the operation, and so the operation takes longer. Our interviewees disagreed with this theory, saying no, it's the same in a keyhole operation or a robotic operation. You watch the screen and so you can anticipate what the surgeon's going to need. But obviously this depends on having a team who are familiar with the operation and who do watch the screen. So it ties in with the issue of engagement. And as we discussed this in the interviews, the role of experience in supporting coordination became really apparent. So this surgeon describes, if it's a consultant assisting or very experienced trainee, then they'll do something. They'll notice that there's something they can do to help exposure, and they'll make the operation easier. And it's quite difficult to communicate that to a junior or an inexperienced assistant. So the surgeons felt that in robotic surgery they're more dependent on the assistant, because you can't just grab the instrument yourself because of that physical separation. And that's something that you will see in keyhole operations. If the surgeon's asking the assistant to do something and they can see that the assistant doesn't understand their instruction or is having difficulty completing it, they'll literally just take the instrument from their hands and do it themselves. And it's very difficult for training, that you can tell but you can't show because of the physical separation and because of the communication difficulties. And as a consequence of this, in a number of sites, they were using experienced operating department practitioners as assistants, whereas previously they would have used trainee surgeons. So moving on to theories about decision making, we started with the theory that when the team's experienced in robotic surgery, they understand that the surgeon's situation awareness is dependent on them orally communicating information. And they respond by communicating more information about the patient's state, which in turn improves the surgeon's situation awareness. The surgeons did feel that their situation awareness was reduced in robotic surgery, and the main strategy that they talked about for overcoming this, in line with our theory, was establishing good communication links with the team. The team did see themselves as the surgeon's eyes and ears, but interestingly what they described notifying the surgeon about was not about the patient's state, but it was about the robot state. So things like the robot arms coming too close to the patient, or the robot arms clashing. So for the team to orally communicate information to the surgeon, you need teams that are willing to speak up, to say, you need to stop now, the arm's about to hit the patient. Now that, they said, just depends on the relationship with the surgeon. So that can be about individual personalities and approaches, but they also talked about the benefits of team training and having a dedicated robotic team in terms of improving the relationship so that they would feel confident to speak up. So another theory that we had relating to decision making was about the lack of tactile information that you get in robotic surgery. So surgeons progress more slowly through a robotic procedure because they don't have tactile information to inform their assessment of the situation. But this effect becomes less pronounced as experience with robotic surgery increases. So several surgeons talked about initial experiences with robotic surgery where due to the lack of tactile information, they hadn't realised how much force they were applying and had applied too much force and, for example, snapped a suture. But none of the surgeons thought that the lack of tactile information was a significant problem. So some talked about being a bit more careful, but they didn't think that it would be enough to lengthen the operation duration. They felt that they quickly adapted to relying on visual cues, learning to look for tension. Okay, and then I think this is our last theory relating to decision making, was that the sense of immersion that the robot provides means that the surgeon's more focused, resulting in improved decision making and patient outcomes. The surgeons talked about, so they agreed that the robot does create a sense of immersion, and they had a number of theories about the contextual factors that contribute to that sense of immersion. So one thing was the trust in the assistant, the confidence that they have in the assistant's abilities. So if they don't trust the assistant, they're going to be pulling their head out of the console to check what the assistant's doing, which means that it's harder for them to feel that sense of immersion. In terms of the impact on patient outcomes, some surgeons felt that the immersion leads to increased focus, which could, for example, lead to a more precise dissection, whereas other surgeons felt that it was harder to comment, or that it was harder to say whether or not immersion would be reflected in patient outcomes. So we've now moved on to phase 2 of the research, where we've been doing a multi-site case study across 4 hospitals, where we've been observing and video recording both robotic and keyhole operations. So for the observations, we've been using an observation tool called OTAS, which stands for Observational Teamwork Assessment for Surgery. We've also been conducting brief interviews after the operations, and we've also been using the Surge TLX, getting them to complete that after the operation. So the Surge TLX is a questionnaire. It's based on the NASA Task Load Index, and it gets members of the surgical team to rate their perception of the physical workload associated with the task, the mental workload associated with the task, and also looks at things like time pressure and distractions. So we've just finished this phase of data collection, and we're still in the process of analysing that data, but I thought it would be useful to say a bit, just to present you with one of the theories and give you some kind of initial reflections on that. So one of our revised theories from the interviews was that if you use an experienced assistant, their knowledge and experience will enable them to anticipate the surgeon's requests and react to events without prompting. This supports coordination between the surgeon and the assistant and ensures that the assistant's actions are performed in a timely manner. So when we observed the robotic operations, when there was an experienced assistant, we actually saw very little unprompted action, but certainly with an experienced assistant, they were able to respond promptly and to do things correctly. We saw several operations with an inexperienced assistant, and what was interesting there was comparing those where you had an experienced scrub nurse who could support the assistant and those where you didn't have that, highlighting the role that the scrub nurse plays. So we saw one operation where it was a surgical trainee who'd never done robotic surgery before, and a scrub nurse who had limited experience of robotic surgery. And when it came to changing the instruments on the robotic arms, things were done incorrectly. The robot arm was pushed in too far, so it nicked the patient and you had bleeding. Nothing that couldn't be resolved, but obviously a patient safety issue. Whereas in contrast, we saw several operations where you had assistants at different levels of training but with no experience of robotic surgery, but they were supported by an experienced scrub nurse who could guide them on what to do. So don't get me wrong, I'm not saying things were always done promptly, and there was one operation in particular where it was really frustrating for the surgeon how long it took, but things were done correctly. Things were done correctly and safely, which suggests that what we need to do with our theory is revise it, that it's not just about the experience of the assistant, but it's about the skill mix of those at the patient's side. Okay, so moving on to reflect now. I thought I'd like to say something about the teacher-learner cycle interviews. So the teacher-learner cycle interviews allowed us to refine our literature-based theories, which were almost completely from the perspective of the surgeon, to reflect the experience of a broader range of participants, providing a focus for the next stage of data collection. But I think what's most important, what I found most useful about this approach to interviews, was that the interviewees really engaged with the theories. So we had some people who'd thought beforehand about how does robotic surgery impact teamwork, but for most of them they hadn't. And I think we got much richer data than we would have if we'd just gone in asking open-ended questions. And in fact, we did ask open-ended questions, so it's quite interesting comparing those responses and what they actually said when we gave them the theories. because you're giving them something to test their ideas against. So I just wanted to say that I think whether you're doing realist evaluation or not, I think this approach to interviews is really useful when you're asking people about a topic that they might not have thought about much before. Okay, and then finally about realist evaluation. So, and how it can contribute to understanding technology use. For me, realist evaluation offers a number of benefits. So, I come from an HCI, CSCW background, and I've spent most of my career doing detailed studies, detailed ethnographic studies of how healthcare professionals do their work. What realist evaluation offers me is a way to meaningfully combine detailed studies of how technology is used, the stuff that I find really interesting, with the gathering of more quantitative data that policymakers want. So I think, and I include my own work in this, that studies from HCI and CSCW, I think it's changing now, but those studies of healthcare, often the patient has been absent because the focus has been on how healthcare professionals are using the technology and the impact of that on the work process, without going on to think about the consequences of that for the process of patient care and patient outcomes. So realist evaluation offers a way to answer the so what question. The other thing that I like, again from a personal perspective, is that often in qualitative studies, and again, I include my own work in this, we identify the contextual factors that influence the outcomes, but the relationships between those aren't very clear. So for example, if I look at my own work on handoffs, we had like one shopping list of contextual factors that seem to influence things, another shopping list of ways in which the process of handoff could vary, and another shopping list of possible outcomes. But the links between those weren't clear. So what I like about realist evaluation is the increased specificity of the relationship between contexts, mechanisms, and outcomes. So then thinking more generally, not just my personal reflections, but thinking about, I think it also has benefits in terms of informing implementation. Because you're looking at in what settings does it produce the desired outcomes, it can inform where it's best to implement the technology, but I think also it can inform implementation strategies. So for example, in our work we've seen the benefits of having team training. So you can design those implementation strategies which help to create the contextual factors for success. It also helps you to understand the contribution of different components or different features of a technology to the outcomes, to the impacts. So when we have different theories, they're often related to different features of the technology. And so this can inform subsequent design. So for example, there's lots of research looking at how you can provide haptic feedback in robotic surgery. But actually in our interviews we found that lack of tactile information wasn't a persistent concern for the surgeons, whereas lack of situation awareness was. So focusing on that is more likely to be a fruitful area for design. I think the other thing it offers is a way to allow design knowledge to accumulate. So if we become more explicit about the theories that underlie our designs, we can then go out and test those theories. And then the refined theories that emerge from that we can use to inform subsequent designs. So I will finish there, and I'm happy to take any questions.
So we're going to use the mic. Yeah, Gloria? Yeah.
Thank you. Very interesting talk. So I was very interested when you were talking about situation awareness and how the communication actually seemed to get the surgeon to focus attention on the robotic arm. And then you also talked about the idea of immersion, which made, for some doctors, made them more focused on the patient experience. Yeah. And so it seems like there are two different things going on, a focus on the robotics and also a focus on the patient. So can you talk a little bit about why sometimes there's focus on robotics, why sometimes on patient?
So I don't think it's that the surgeon's focused on the robotics, it's that in fact the surgeon isn't aware of the robotics. So for example, if the robot arms are clashing, what the surgeon realises that he's not managing, he's trying to do things and it's not working. He's trying to move the robot arms in a certain way, but unless he pulls his head out, he doesn't know that. So it's dependent on the team telling him. So he's not aware of that if he's staying in the console. And I think that the focus, kind of the immersion, it's the immersion in the surgical site. Kind of completely, because you've got this 3D and it's also a magnified image of the surgical site. So I think what they want from the surgeon's perspective is to stay focused on that area. But I mean, one thing that they talked about, actually another kind of contextual factor, was that if they trust their team to communicate information to them, they're less concerned about their reduced situation awareness, and that allows them to then just focus on that surgical site. Yeah.
I'm curious, what is this?
Please use the middle.
I think I'm fine without it. Okay. So my question is involving adoption. Since a lot of this new technology is largely very new for one, it's new. So there's not a lot of data on it, and there's not a lot of evidence, so to speak. You know, what's the incentive for, say, doctors and hospitals and a whole team to buy a $2 million machine and spend how many weeks training on this thing if there's not really good evidence that'll make them do the job better?
Okay, so there's several answers to that question. So one is to say, with a technology like robotic surgery, unless people use it and learn to use it, you'll never be able to do a randomized controlled trial to find out if there is evidence. So, you know, and that's part of the reason that there isn't evidence, that we've only recently got to a stage where, you know, our trial was an international trial where you've got enough surgeons, you've got enough experience of using the robot for colorectal cancer to be able to do a trial. I also think the situation's different in the UK to the US. So from looking at the literature on this, is the way that the robot is promoted. So, and actually it happens in the UK as well. So one of the things that we did when we were looking for stakeholders' theories, we just typed NHS robotic surgery into Google, and what you get are all these hospital websites, NHS hospitals saying, we've bought a robot and it costs $2 million and it's the latest technology. So patients think that must be the best thing then. It's the latest technology and it costs $2 million. So my understanding of the situation in the US is that Some hospitals feel that they have to purchase a robot because otherwise those patients will choose to go to a hospital that does have a robot. When we asked surgeons about their motivations for starting to do robotic surgery, they talked about a number of things. One was this idea that the robot as it isn't great. It's not going to have huge benefits. But if we don't learn to use the technology now, and if we don't start taking up that technology, it's never going to improve. So it's about kind of hopes for the future. Something else they talked about was about attracting staff. That if you're seen to be a high-tech, innovative institution, you will attract those innovative surgeons, the best surgeons, to come and work with you.
How long do you see the time horizon before it becomes more commonly adopted?
In the UK, the NHS has just said that for prostate cancer surgery in high volume centres, it recommends the use of robotic surgery. So that's one distinct area where it is going to become more common. The results of the trial that we've been doing this work alongside have come out for their primary outcome, which was conversion to open surgery. So the assumption that because robotic surgery makes keyhole surgery easier, you should have fewer conversions to open surgery. And actually they found that there was no statistical difference. In fact, when you look at the raw numbers, there were fewer conversions to open surgery with the robot. So obviously that's what Da Vinci promoted, but actually there was no statistically significant difference. But we do need to wait for those follow-up outcomes about sexual function and continence, because as I say, with prostate cancer, they have found that there's benefits there. So I think gradually the evidence is building, and I think that will decide the future for robotic surgery.
Thanks. This is really an interesting talk. I wanted to go back to focus a little bit more on the realist evaluation, and I guess maybe pose a question. I'm not sure I'm going to be able to get it out correctly, but just a thought that I'm thinking about in this. And one of the sort of features in the way that you described it is this careful definition of both the mechanisms or the focus and the context that you're dealing with. And I'm curious about how you decide which of those is which. And thinking a little bit of, Jeff Bowker, who I don't think is here today but is in our department, and others have focused on things like infrastructural inversion or figured ground flips as actually an analytic technique to better understand that relationship between text and context.
Yeah.
How do you think about what those are in this kind of a case?
Yeah, so again, there's several things to say about that. And looking at kind of studies of realist evaluation, that's something that people often struggle with, about is it a context or is this the mechanism? And then the outcomes of some theories will become the context for another theory. We took the approach in a way to not worry about it too much. Do you not only the idea is to get the theory and then you can test it. But I think in terms of thinking about what's the appropriate contextual factors, for us that came through the interviews. So in order to decide kind of the factor that we're going to look at in our data collection, the thing that kept coming up in the interviews was about experience. So that was how we decided to focus on it. But I know, so Ray Pawson, who developed Realist Evaluation and created this idea of CMO configurations, I think has now said that sees it as less important. It's the ideas, really. Yeah.
I have a question.
Yeah.
I really liked your talk, and I thought you're not only testing theories, but you're also propagating the knowledge from the theories to the physicians.
Yes, yeah.
And so you are actually training them about
Yes.
what is the best knowledge we have so far,
Yeah.
testing it and
Yeah, and that's the interviews, that's why they call it the teacher-learner cycle, because first of all, the interviewer is teaching the interviewee about their theories, and then the interviewee becomes the teacher and helps you to revise those. But yeah, and I think probably we did have some influence. I think we try to avoid influence in research, you know, we see it as bias, but actually I had a couple of surgeons come back to me after doing the interviews and say, you're right, you know, it does impact teamwork. Yeah. So.
one more.
So I never went to surgeon school to my parents' disappointment, but do you think it's possible that you guys train new surgeons on the machines, people who have never been conditioned to use traditional methods, sort of like how newer generations of kids seem to be a lot more adapted to new technology and they just use it almost secondhand? Do you think that could actually affect the outcomes of these surgeries when they use a robot?
I don't know. The only thing that I can say in response to that is that the colorectal surgeons that we interviewed, they'd all been doing keyhole surgery before, and actually they felt that doing keyhole surgery had provided good training, had helped them develop the skills that they need for robotic surgery. And I think the reality is you're always going to need skills in open surgery. So it's kind of, you can't just go straight to the technology. You need, all surgeons would need a variety of skills.
Okay, let's thank her again.